today is Children's Day, which is our constituency. And we just finished having our Pan Children's Day activity successfully in Port Harcourt. So a lot going on. And so we appreciate your presence here. This webinar is in collaboration with the Paediatric Nephrology Association of Nigeria, PNAN. They are going to be the one hosting us today. And it is, I think I can see the moderator is here, Dr. Patience Obiagwu, and the speaker, Dr. Datonye Briggs. So I want to welcome you all, distinguished colleagues, facilitators, invited guests, ladies and gentlemen. On behalf of the Executive Committee Council of the Paediatric Association of Nigeria, I warmly welcome you all to this important webinar on steroid-sensitive nephrotic syndrome, a focus on treatment guideline and follow-up. It is a pleasure to have such a distinguished gathering of pediatricians, trainee healthcare professionals, and stakeholders committed to improving child health and outcomes in Nigeria and beyond. Steroid-sensitive nephrotic syndrome remains one of the most common chronic kidney diseases encountered in pediatric practice. While many children respond well to therapy, achieving optimal outcomes and requires not only accurate diagnosis and evidence-based treatment, but also diligent follow-up, family education, monitoring for relapses, and prevention of complications. Today's webinar provides an excellent opportunity for us to deepen our understanding of the current treatment guidelines, share practical experiences, and strengthen our capacity to deliver standardized high-quality care to affected children. I sincerely appreciate our esteemed resource persons who have taken time to prepare and share their expertise with us. I also commend the organizers, that is PNAN, and all who are participating for prioritizing continuous professional development and collaborative learning. We thank you very much. As we engage in today's discussion, I encourage everyone to actively participate, ask questions, and contribute meaningfully to the conversation. Together, we can continue to improve outcomes for the Nigerian children. So you are welcome. I will now hand over to the moderator of this session, Dr. Patience Obiagwu, to take it from here to introduce the speaker and commence the webinar. Thank you. Dr. Patience?
Good afternoon. Am I audible?
Yes, you're audible.
Yeah, Presido, good afternoon.
Good afternoon. Well done.
Good afternoon, everyone. It's an absolute pleasure to be anchoring this session. There was to be a welcome address by our chairperson. I'm not sure if he's on here. Prof. Ocheke, I'm not sure he's on. Okay, he was, according to the program, he was supposed to give a welcome address.
He's not on. When he does, maybe
yeah, I can see that. Yes, I can see that he's not on. Yes. Okay, so I welcome everyone to this going to be very engaging webinar being hosted by the Paediatric Nephrology Association of Nigeria, PNAN. I say good afternoon to immediate past president is here, Prophet Kure, and very many other persons. So not to take much of our time, I will just go ahead and give a brief introduction of the person going to be presenting this topic, steroid-sensitive nephrotic syndrome. So it's an immense pleasure for me to introduce our distinguished guest speaker for today, who is Dr. Christopher Datonye Briggs. He currently is an associate professor of pediatrics and child health at the Rivers State University, as well as an honorary consultant pediatrician and pediatric nephrologist of the Rivers State University Teaching Hospital in Port Harcourt. Datonye completed his residency program at Uniport and was awarded a fellowship by West Africa College of Physicians, notably graduating with a distinction and also receiving prizes. He received his subspecialty training in pediatric nephrology at the renowned Red Cross War Memorial Children's Hospital and University of Cape Town. I'm proud to say this is also where I was trained. And under the mentorship of same tutor, Prof. Mignon McCulloch. Datonye had been very exceptional, and he also came out of South Africa with collecting their distinction as well. He received a rare certificate of merit. And he's also a fellow of both IPNA, International Paediatric Nephrology Association, and ISN, International Society of Nephrology. He has other certificates to his credits and diploma. He's a highly prolific researcher. He has authored over 60 peer-reviewed scientific publications. His areas of interest including childhood nephrotic syndrome, acute kidney injury, amongst others. He is presently a secretary at the PNAN, Paediatric Nephrology Association of Nigeria, but is also an IPNA member on the Communications Committee, as well as on the Communications Committee of the African Paediatric Nephrology Association, the AFNA body. So, ladies and gentlemen, please welcome with me Datonye Christopher Briggs, who is going to be talking to us for the next 40 minutes on steroid-sensitive nephrotic syndrome. Datonye, are you on?
Yes, thank you very much. Prof, can you hear me?
Yes, I can.
Thank you very much. Could I have the IT, please allow me share my slides? Okay. Are my slides visible?
Yes, yes.
Yes.
On presenter mode?
Yes.
All right. So without further ado, thank you, Professor Obiagwu, for the warm introduction, and good afternoon, everyone. Permit me to acknowledge all my trainers, teachers, and very senior colleagues on this call. I do really appreciate and thank the Paediatric Association of Nigeria, the president, and executives, as well as the Paediatric Nephrology Association of Nigeria for giving me this opportunity to give this talk today. This will be the outline of my talk, and without further ado, I go into it. So nephrotic syndrome, as we are all aware, is a disease, is not a disease in itself. However, it is a manifestation of a type of glomerular injury. And idiopathic nephrotic syndrome is the most frequent glomerular disease worldwide and affects about 1.2 to 17 per 100,000 children. It is a leading cause of chronic kidney disease in sub-Saharan Africa and end-stage kidney disease as well. 80 to 90% of children with idiopathic nephrotic syndrome are predominantly steroid sensitive. And in Africa and Nigeria, about 2/3 to 3/4 of cases are steroid sensitive. Nephrotic syndrome has been observed to affect more males than females. The Canadian Childhood Nephrotic Syndrome Database Registry demonstrates that idiopathic nephrotic syndrome is commoner amongst 2 to 5 years, children of Caucasian origin. And of course, it's this seminal paper that was presented by Dr. Ademola et al. Showed that the mean age at presentation in African children was 7.3 years, suggesting a delay in presentation. Of note, however, was that patients had steroid-sensitive disease, more than 50% of them. Data from the Paediatric Nephrology Association of Nigeria renal database, with over 500 pediatric entries across 23 institutions in Nigeria, shows that glomerular disease is the predominant disease in our setting as well. And of the 258 patients with nephrotic syndrome, 80% of them were steroid sensitive, and we also observed a trend towards a male preponderance. When we mention idiopathic nephrotic syndrome, We actually mean idiopathic, meaning till now, the cause is still elusive and it primarily originates in the kidney. When we say childhood nephrotic syndrome, we mean between ages of 1 to 12, because we have other classes of nephrotic syndrome based on age. And of course, when we classify based on steroid responsiveness, whether the child is responsive to steroid or not. And this will be the focus of my talk. And when we do histologies, children who are steroid sensitive appear to have minimal change disease on biopsies. So steroid responsiveness is most important classification, irrespective of age, etiology, histopathology, because as long as patients, pediatric patients, are steroid responsive, they are often not biopsied, and a majority of steroid-sensitive patients have good prognosis. Primary idiopathic nephrotic syndrome is quintessentially an intrinsic disorder of the podocytes, so they tend to have what's called podocytopathy, and it centers on podocyte injury, disrupting the sleep diaphragm, loss of size or charge selective permeability, and allowing protein to leak, of course. So when there is an infection or allergy or genetic predisposition, this leads to immune dysregulation, abnormal T-cell activation, then circulating permeability factors from these abnormal T-cells. This leads to podocyte injury, disruption of glomerular filtration barrier, and increased permeability to protein. This gives us the clinical manifestations we attribute to nephrotic syndrome. Steroids, on the other hand, are used when we want to treat these children, and it causes immunosuppression. It suppresses these abnormal T cells, activation and cytokine release, causes direct podocyte effects by stabilizing the podocyte cytoskeleton, and of course restores the filter or the filtration barrier, which enables us to decrease proteinuria, improve hyperalbuminemia and the edema. And this is what we eventually say the child is in remission. This electron microscopy shows the glomerulus with the podocytes, primary and secondary podocyte food processes interdigitating. And when we do an electron microscopy, we find this is what is supposed to be normal, protrusions of the food processes, but then in minimal change disease or steroid-sensitive nephrotic syndrome, we tend to have an effacement of the food processes. This slide reminds me that idiopathic nephrotic syndrome is a relapsing and remitting disease. And although largely steroid sensitive, about 80% of them will have a relapse in their clinical course, and 50% of them have different clinical phenotypes, including frequent relapsers and steroid dependence. I will focus more on steroid-sensitive nephrotic syndrome today. So let's go into the guidelines. A nationwide survey was conducted in 2022 by Dr. Briggs and Professor Datonye, which aimed to assess the prescribing patterns of new onset nephrotic syndrome among pediatric nephrologists and pediatricians in Nigeria. And this study revealed that about 85% prescribed prednisolone at the standard recommended dosing. However, the duration of initial and total prednisolone administration differed, and that also strengthens our discussion for today. Yeah, so the key milestones have been noted in the formulation of guidelines for children with nephrotic syndrome. The International Study for Kidney Disease in Children, that's the iECHO, in the early 70s was the first standardized childhood nephrotic syndrome protocol. That was where it came out from. Subsequently, we had other guidelines. The KDIGO in 2020 had something on glomerular diseases and sort of highlighted something on nephrotic syndrome. But we then had the Ibadan Consensus, which was the Sub-Saharan African Management Statement. Afterwards, we had the International Paediatric Nephrology Association coming up with the clinical practice recommendations for steroid-sensitive nephrotic syndrome. And in 2025, KDIGO again, that is Kidney Disease Improving Global Outcome, which is like the global body, also made a statement on the global clinical practice guidelines for nephrotic syndrome. I will be focusing on the IPNA guidelines as pediatric nephrology and also make some remarks about the Ibadan Consensus going forward. So this is the Ibadan Consensus paper that was published in the Kidney International Journal, and the contributing authors were listed. At this point, permit me to truly acknowledge the heroic first of its kind consensus statement put forward by a plethora of both pediatric and adult nephrologists practicing in sub-Saharan Africa, which was to serve as a guide for managing childhood nephrotic syndrome within Africa, that has contributed in no small measure to advancing management of pediatric kidney disease in Africa. Also, we have the IPNA guidelines and the KIDIGO guidelines. And I would, like I said, talk a little bit about mostly of the IPNA guidelines. I wouldn't bother you so much with the methodology, but what I would want to say is that the American Academy of Pediatrics grading of evidence was used. And so when you see in my talk a level A recommendation, I simply mean that well-designed and conducted trials were assessed before a consensus agreement was reached and strong recommendations were made, and subsequently going, lower based on the evidence. So what is nephrotic syndrome? Nephrotic syndrome now is being defined as nephrotic range proteinuria, where you have a spot urine protein creatinine ratio greater than 200 milligram per millimole or 2 milligram per milligram, or a urine dipstick analysis of greater than or equal to 3 pluses of proteinuria, and hypoalbuminemia with serum albumin less than 30 grams per liter, or edema when serum albumin is unavailable. Hyperlipidemia, yes, is a hallmark feature, making it one of the major manifestations of nephrotic syndrome, but it's really not part of the core clinical definitions, as it is just the child. I put the dipstick up here so that we'll realize that when we say 3 pluses and above, it means that the child pees greater than 300 milligram per DL of protein. However, the spot urine protein quantitatively is still preferred, but urinalysis can and is still acceptable. When the child comes to you and you think the child has nephrotic syndrome, there is a standard workup that is now recommended. I'll talk about that, but straight up, I would want to mention that biopsies and genetic testings are not required as initial workups for children with typical nephrotic features, especially above the age of 1. Infantile onset, those between the ages of 3 months and 12 months, can be considered for genetic testing or kidney biopsies, but of course, as you can see, it's weak recommendation. So we would start with the clinical evaluation of this child. So typically, a child with nephrotic syndrome will present with periorbital edema, which is the leading clinical sign that they would have in the typical presentation. It usually may be asymmetrical initially and is frequently misdiagnosed as allergies by some younger doctors. Edema is usually gravity dependent, localized in the lower extremities, in the upright position, and in the eyelids and in dorsal parts of the body in a reclining position. The edema is usually painless, soft, and pitting, leaving marks from clothing or finger pressure. Of course, the child may also have an ASACA as well, which may develop as ascites, pleural effusions, or pericardial effusions. Complications may also be presentations such as fever, pain, abdominal discomfort, and fatigue, which suggests, severe hypovolemia, ascites, peritonitis, or having a pneumonia. But I must highlight here that a child who has nephrotic syndrome should also have other differentials excluded, including, but not limited to, heart failure, severe malnutrition, thyroid disorders, of course, liver diseases as well. So the guidelines also say that, of course, especially for us living in endemic areas, before we ever start immunosuppressants, we must rule out secondary causes of nephrotic syndrome, which includes sickle cell disease, HIV, lupus, malaria, and of course, screen the children for tuberculosis. On physical examination, you want to check the blood pressure of this child. You want to know the volume status of the child. Remember, they can either be intravascularly depleted or normal. So you must assess this. Of course, the extent of edema, including ascites, and checking if they have pericardial or pleural effusions. Lymphadenopathy, which may suggest, of course, infections plus minus malignant changes. If the child has a malignancy, that may present as if the child has nephrotic syndrome. And signs of infection, respiratory tract, skin, peritonitis, and urinary tract infections. It's also recommended that extrarenal features be looked out for. These include dysmorphic features, ambiguous genitalia, which suggests other genetic conditions like Fraser syndrome or Dennis-Brash syndrome, eye abnormalities, and microchoria or aniridia, all right, and rash and arthritis, which may also suggest things like lupus. Anthropometry should be done for every child who comes into your clinic for nephrotic syndrome, and you should please compare with appropriate national standards. Vaccination history is very important, especially looking at the pneumococcal, meningococcal, and Haemophilus influenza vaccines, and of course hepatitis, well, SARS-CoV-2 according to the international guidelines, and varicella. History of kidney disease, have a spot urine protein creatinine ratio done on the first void. That is what is which is very important. Standard bloods are also required, your complete blood count, your creatinine, to calculate your eGFR, check the child's urea, electrolytes, and albumin. You should calculate the estimated GFR, and we use the bedside Schwartz formula, which is your the formula stated here. If you use creatinine, then your constant K, which is K times T over the serum creatinine, your constant is at 6.5. But if you use milligram per GL in your center, then your constant should be 0.413. If the child presents with macroscopic hematuria, then it's important that an immunological panel also be added to the list of investigations, including complement C3 and C4, your anti-nucleic acid antibodies, your anti-streptococcus. Only want to consider if you think the child has kidney malformations, venous thrombosis, or has reduced eGFR at presenting with hematuria, abdominal pain, or before you think the child may benefit from a biopsy. Chest x-rays are usually, well, not necessarily. For our setting, most likely will be complicated pneumonia or pleural effusion of some sort, but they recommend for lymphomas. So x-rays and kidney ultrasounds are technically not required. Histopathology, kidney biopsies, like I said, if the child has typical features, you shouldn't do a kidney biopsy. But if the child has atypical features, what do I mean by these? With hypovolemia, sustained hypertension, arthritis, rash, and the patient has already been diagnosed with steroid-resistant nephrotic syndrome, you'd want to consider doing a biopsy. If the child is having infantile onset nephrotic syndrome between 3 to 12 months, then you may also consider biopsies. Biopsies of children above 12 years is largely on a case-by-case basis. Genetics, of course, we don't do that much in our own setting, but it's recommended where children have congenital nephrotic syndrome or patients are diagnosed with steroid-resistant nephrotic syndrome, and it's likely because of whether or not you want to go on with immunosuppressants. And of course, you may consider if the child presents between the age of 3 to 12 months. So this is the algorithm that we should look at. And we have two aspects of the algorithm. If the child is less than 3 months or has extrarenal features or a family history suggestive of syndromic or hereditary steroid-resistant nephrotic syndrome, or the child has atypical features. So if the child has atypical features, you would get my pointer. If the child is less than 3 months, you may think of genetics or and there is a guideline for congenital nephrotic syndrome. If the child has atypical features, then you would want to consider doing a biopsy first, because this child may not have minimal change disease or may less likely be steroid sensitive. But for us, what is more important is this part of the guideline where the child presents with the normal typical features, 1 to 12 years old, and you want to think of starting steroids. So what is your first primary immunosuppression agent that you want to use? The guidelines have said now that we should have daily prednisolone, and there are 2 protocols. You either have the 4-week protocol or we have the 6-week protocol. The 4-week protocol using the daily phase and an alternate day phase. The daily phase will be 60 milligram per meter square or 2 milligram per kilogram, maximum of 60 milligram per day. Then you will do that for 4 weeks. The child enters into remission, which I'll talk about. And then, of course, alternate day phase for another 4 weeks, where you skip 1 day every other day, and you will do that for 4 weeks with a maximum dose of 40 milligram. And so your total duration is 8 weeks, or you would do a 12 weeks, 6 weeks, respectively. What would be the dosing rules? You should administer your prednisolone as a single morning dose, no more divided doses. No tapering during alternate dosing. Before, they used to feel you can actually taper, but now the rule is no more tapering, because there really is no fear of suppression of the pituitary adrenal axis. And of course, you calculate your dose for weights or body surface area based on the estimated dry weight. So not when the child comes in so fluid overloaded, you have to estimate the dry weight for this child. And children who are smaller, technically less than 8 years, less than 30 kilograms, the body surface area is preferred. And those who are above 30 kg, the weights is preferred to be used. Remember that initial episodes, you do not need to have any other immunosuppressants. Prednisone and prednisolone can be used interchangeably, and we have liquid formulations and tablet formulations. But in our own environment, we use more of the tablet formulations. So that's what we use, and we round them up to 5 milligram. When this child comes, you started the child on steroids. The question is, how do you monitor this child? So primarily, you must educate the families to monitor the urine at home, so that you want to identify early response to prednisolone and if there are relapses. So what do you use? Your urine dipsticks is what you use. The alternative methods of heat coagulation are largely not used. They are very weak recommendations. In our environment, we prefer to use the urine dipsticks. How do you monitor these patients? You have them do daily dipsticks in active phase daily until they enter into remission. And once the remission is over, they would have daily dipsticks done twice weekly for at least 1 year. Kidney biopsies, like I said, are generally not done. You would want to only consider that when you think it may influence their therapy or classify prognosis in steroid-sensitive nephrotic syndrome. Maybe the child is on a steroid-sparing agent like your CNIs or calcineurin inhibitors, or the child shows signs of toxicity. So like I said, in active disease, daily until remission, and during remission, at least twice weekly in the first year, and afterwards you can individualize. But once you have alert triggers, say the mother checks and the dipsticks is 1+ or more than 1+, the child has a fever or infections, or you're suspecting this child may have an edema coming up, then it will go back to daily. So when you clinically evaluate this child, you want to make sure on outpatient basis, this child should visit you every 3 months, and within the first year, you can individualize that based on how frequently the child relapses. You want to monitor symptoms at every visit: fever, abdominal pain, swelling, fatigue, appetite changes, weight gain, and of course, you want to screen for infections and drug toxicities at every visit. You would want to check their blood pressures. This is recommended. You want to assess them for their volume status, for edema, ascites, pericardial or pleural effusion, and of course, drug toxicity screening. So when the child comes, if the child's on steroids, you want to look out for Cushingoid features, and you want to ask for acne, tremors, and depending on whatever steroid-sparing agent the child is on. You also want to check for signs of infection and ophthalmological examinations for children who are on steroids. This is something we often don't do, but the guideline highlights, at least if this child is on steroids, should have yearly eye examinations as well. Anthropometry is very important. Remember, steroids affect growth, and you want to assess that this child is growing and checking the height, velocity, and BMI so that the child doesn't tip over, because of the side effects of steroids. Now the child has started his steroids. How do you define that this child has completely gone into remission? You would want to make sure that you are assessing, so complete remission is checking your spot urine protein creatinine ratio and it should be less than 20 milligram per millimole, or dipsticks that are negative or trace for 3 consecutive days. There is something called partial remission, where the spot urine protein creatinine ratio is above 20 but less than 200 milligram per millimole, and serum albumin is above 30. Now the child has taken your medications. When you say this child is steroid sensitive, you would say this child is steroid sensitive when the child has completely gone into remission within 4 weeks of prednisolone at the standard dose of 60 milligram per meter square or 2 milligram per kilogram. You would also want to say this child is not steroid sensitive, steroid resistant, if the child has not gone into remission within 4 weeks of standard dose of therapy. There's something now called the confirmatory period, where it's between weeks 4 to 6, you're assessing, the patient who has gone into partial remission after initial prednisolone. And what is required is that you give the child oral prednisolone or even IV methylpred pulses combined with your RAS inhibitors, so your enalapril ACE inhibitors, and you want to assess this child's response to treatment, and your evaluation would be at 6 weeks. If this child has gone into remission, then this child is a late responder and is classified as steroid sensitive. If the child, however, still remains in partial remission or did not go into remission at all, that child is classified as steroid-resistant nephrotic syndrome. So what is your first-line therapy if the child comes in relapse? So this child has gone into remission, but the child comes in relapse. How will you say this child is in relapse? Your dipsticks is what you will use. We say grade 3+ or more on dipsticks, or the person's spot urine protein creatinine ratio is above 200 milligram per millimole, and it must be on spot urine samples on 3 consecutive days, with or without the appearance of edema in a child with previous complete remission. Now there is a new term called complicated relapse. If the child relapses but has severe edema, symptomatic hypovolemia or AKI requiring albumin infusions, thrombosis, severe infections, this child requires admission, and that is what is called a complicated relapse. What do you do when the child has a relapse? You would want to give the child high-dose prednisolone again at 2 milligram per kilogram or 60 milligram per meter square per day, and you will do that until the child has achieved remission for 3 consecutive days. After that, you will give an alternate day phase at 1.5 milligram per meter square of maximum of 40 milligrams for 4 weeks without tapering, and that is it. For some children, they would have upper respiratory tract infections, and we know that some of them, when they have infections, can relapse. The guideline now says no routine, short course, low dose daily prednisolone at the onset of upper respiratory tract infections to prevent relapses. However, you may consider this short course, low dose prednisolone if the child has upper respiratory tract infection but is already taking alternate day prednisolone and has a history of repeated infection-associated relapses. Of course, the child comes in with secondary, so second-line therapy, you have this child who keeps relapsing. You are worried because the child now has begun to relapse, and you are worried that this child may need more steroids. But the reason for second-line therapy, which is now being pushed, is that they want to prevent or minimize severe glucocorticoid-related toxicities. You want to achieve long-term relapse preventions. You want to lower the threshold dose for alternate-day steroids, and you want to manage steroid-dependent or frequent relapsing disease courses. So, of course, remember, when a child presents with new onset or worsening obesity or overweight, sustained hypertension, hyperglycemia, behavioral psychiatric disorders, sleep disruptions, you are worried, or cushingoid features, striae, you are worried that this child has steroid toxicity. So the new terms for the clinical phenotypes have had slight modifications to their definitions. So now, once a child enters into remission, if the child has fewer than 2 relapses in 6 months following the remission of the initial episode, or fewer than 3 relapses in a subsequent 12 months. So 1 relapse in 6 months, 2 relapses in a year, you say this child is an infrequent relapser. If the child has 2 or more relapses in 6 months, or 3 or more relapses in 12 months, that child is a frequent relapser. If, however, the child now relapses while on the recommended prednisolone dose, so you were on 60 milligram per meter square or maximum of 60, and the child went into remission, and you tailored down to 40, and the child was on alternate day prednisolone and relapsed while on alternate day prednisolone, and this has happened on 2 consecutive occasions. Or the child has had complete remission for 14 days, you've stopped alternate day, the child, within 14 days, the child relapses again. That child is likely depending on steroids, and so that child is steroid dependent. Other new definitions that are now are sustained remission. So it means no relapses for over a year with or without therapy. Someone is controlled on therapy where is an infrequent relapser, or sustained remission while on immunosuppression in the absence of significant drug toxicity, or not controlled on therapy where the person is a frequent relapser despite immunosuppression, now has significant drug toxicities while on immunosuppressive therapy. That person is not controlled on therapy. And of course, we have secondary steroid resistance, where this person initially was steroid sensitive, responsive, went into remission, but at a subsequent relapse does not achieve complete remission within 4 weeks of prednisolone. So what are the optimal approaches to a child who has frequent relapsing nephrotic syndrome? The guideline says use maintenance treatment for all patients with frequent relapsing steroid or steroid-dependent nephrotic syndrome. And you either introduce a steroid-sparing agent or low-dose maintenance prednisolone, given on alternate days or daily schedule. So for the steroid-sparing agents, you would want to do that for children who are not controlled on therapy, who suffer a complicated relapse, or who have steroid-dependent nephrotic syndrome. So, colleagues, I want you to know that at this particular point, this child is becoming chronic, this child is becoming a bit troublesome and complicated. You need to consider when to refer to a pediatric nephrologist. One would be atypical presentation, where you have atypical features not consistent with idiopathic nephrotic syndrome. The child has a positive family history for nephrotic syndrome, congenital or infantile nephrotic syndrome, age at onset above 12 years, or the patient is steroid resistant, a late responder, frequent relapser or steroid dependent, or has secondary nephrotic syndrome, or the child has drug toxicities or complicated relapses. At this point, as a pediatrician in your hospital, you should involve, if you haven't already, involve a pediatric nephrologist. I'll give you just a snippet into what the pediatric nephrologist will do. The pediatric nephrologist will, according to the guidelines, choose from any of these medications and see whether it will help the child. I won't go into detail because of time. However, we must remember that the child can either be an infrequent relapser. Whenever the child comes, you treat him as single relapses. But once you have a frequent relapser or steroid-dependent nephrotic syndrome, you need to really refer this child to a pediatric nephrologist. This is the algorithm. I won't go into all of that. I've highlighted the steroid-sparing agents, but this child needs to really be supervised and be sent to us. So the other things I want to mention would be adjunctive measures, which would be edema control largely, because when they come, some of them are fluid overloaded. You want to evaluate their volume status, especially if the child has acute nephrotic state. You do not want to restrict fluids to a child who has steroid-sensitive nephrotic syndrome, largely because majority of them are intravascularly depleted. You would only restrict, especially in the hospital setting, if the child is severely edematous and the child has hyponatremia because of the trigger of the onset of your antidiuretic hormone, which makes the child still continue to store, save some sodium, save some water, because the body thinks that it is intravascularly depleted. You would also want to recommend low salt diet during relapses, and of course, normal salt diet when the child is in remission. You want to monitor for hypertension, and we use hypertension guidelines. And we recommend against using ACE inhibitors to control edema or blood pressures, because of course we know that it can cause profound hypotension and acute kidney injury. You want to withhold diuretics if the child has hypovolemia. Remember, the nephrotic syndrome keeps them in a hypercoagulable state, so they are at risk for thrombosis. Some of them can come in severe shock and AKI, so you also want to discontinue your ACE inhibitors or ARBs. If the child is having hypovolemia, the child has as defined as oliguria, AKI, prolonged capillary refill, tachycardia, abdominal discomfort, but blood pressure is not severely affected. You can use 20% or 25% albumin infusions, and you add Lasix or furosemide at the recommended dose midway and at the end of the infusion, and this should be given for at least 4 to 6 hours. If the child comes in shock, it's recommended that you use 4% or 5% albumin without furosemide. And if the child has AKI without hypovolemia, then of course you want to manage the child according to the rules and regulations for AKI management. Albumin infusions are given at the recommended dose over 4 to 6 hours, like I've earlier said. You will use albumin cautiously, especially if the child is hypertensive and those with reduced urine outputs, to prevent hypervolemia and pulmonary edema. And you also want to consider antihypertensives, including diuretics and fluid and salt restriction in the fluid overloaded edematous hypertensive child. So this algorithm just tells us if the child has intravascular volume, if the intravascular volume is maintained, the child has moderate edema, you can restrict sodium. If the child has severe edema, but intravascular volume is maintained, you can restrict sodium, you can restrict some fluid, you may consider albumin and diuretics. However, if the child has intravascular volume contracted, any degree of edema, but the blood pressure is normal, you would want to use your 20% or 25% albumin infusions. And of course, if the child comes in shock, you preferably would use your 4% or 5% albumin infusions and resuscitate accordingly first. Other adjunctive measures would be lifestyle, nutrition, and modifications. This child should have healthy nutrition, avoid high fat, high calorie foods, but low salt diet is imperative for them. However, when they're in remission, they can have normal salt. They should have normal dietary protein intake, and a dietitian's advice for the families where available. Regular physical exercise is also advocated, and of course, the child should not be immobilized. A child with nephrotic syndrome should be allowed to move around if possible, because they are at risk for thrombosis. Anticoagulants are routinely not recommended. And if the child has issues with familial thrombophilia or has thrombophilic predispositions, the child should be seen by hematologists. Antibiotics are not routine for them, and you want to provide prompt treatments if you suspect any bacterial infection. Please cover for strep pneumonia, and of course, vaccinations remain optimal in our setting as well. Steroid minimization is still the key to minimize optimize bone health. You would want to maintain them to be sure you try to minimize your steroids. Alternate day therapy is important, and of course, limiting your duration. You would want to use steroid-sparing agents if you think there is toxicity. Routine calcium supplementation, vitamin D supplementation is not advocated, except they have deficiencies that have been appropriately measured. So thyroid function is also important. You do not go about giving thyroid supplementations, not necessary, because once they get into remission, their thyroid levels become normal. And lipid management using lipid lowering agents also is not recommended, because once they're out of the acute nephrotic state, lipid profiles get better. This is just a algorithm from the KDIGO guideline, which says if the child has new onset nephrotic syndrome less than 12 years, no syndromic features, please give glucocorticoids for either 4 or 6 weeks. If there's no response, this is what you do. If there's complete response, you change to alternate day steroids either for 4 or 6 weeks for a total of 8 or 12 weeks. Then you classify them according to their phenotypes. If the child is an infrequent relapser, when it comes in relapse, give you steroids. If the patient is a frequent relapser or steroid dependent, you will need to refer, because you will need to start steroid-sparing agents. So this is one of my last slides. Comparing the different guidelines, the initial duration according to the Ibadan consensus was 16 weeks. So the Ibadan consensus said an initial dose of 6 weeks and alternate day of 6 weeks, and then we taper for another 4 weeks. And I think that was because they wanted to, if you think somewhat a child was, because of the peculiarities of our environment and the fact that we do not have options to quickly switch to. And even if we change to steroid-sparing agents, monitoring them may be a challenge. But the maximum dose that is required for both IPNA KDIGO was also recommended, and alternate day doses was also recommended by the Ibadan consensus. Definition for frequent relapsing nephrotic syndrome were essentially the same. And for relapse, the only slight difference was now the guidelines say we should have 40 milligram per meter square alternate day and stop at 4 weeks, but the Ibadan consensus recommended initial 40 milligram per meter square per day for 1 week and then taper over 3 weeks. So it was just a slight, difference or adjustment to the guidelines for steroid-sensitive nephrotic syndrome. So in summary, I want us to remind ourselves that IPNA guidelines are international. Ibadan consensus still focuses on the peculiarities in our own setting and is quite a pragmatic and very important guideline. So in summary, please remember that the IPNA guidelines, although designed for resource settings, comprehensive diagnostic and therapeutic infrastructure, Nigeria is such that we can be in the same Nigeria and have different access to resources. So there is the IPNA guideline. There is the Ibadan consensus that is tailored to resource constraint settings. The plan is pediatricians and pediatric nephrologists should actively utilize these guidelines in clinical practice. And PNAN also consider revising the Ibadan consensus following a nationwide review of practices and alignment with the latest IPNA guidelines. Thank you very much for listening.
Thank you very much, Dr. Briggs. Can we give him an e-clap for this very scintillating presentation? I would give an overview of just a summary of what he has just taken us through, and he was very clear. And while I'm giving the overview, if there are more questions, you can put in questions in the chat, and we're able to save about 13 minutes with this and from the beginning. So Datonye has taken us through epidemiology, in which we know is the most common glomerular disease in children. Has told us about the predominant type being idiopathic and being more common than steroid-sensitive, being more common than steroid-resistant type, with the mean age at diagnosis being about 7 years. He has classified it by etiology, by age, where we have congenital, infantile, childhood, or late onset. He has also told us that it could be classified based on steroid resistance into sensitive or resistant steroid response. He took us through the core mechanism, which is podocyte injury, and also took us through steroid action, which suppresses immune abnormalities and stabilizes the podocytes. He has taken us through diagnosis and the initial workup, putting us through the diagnostic criteria, which include nephrotic range proteinuria, as he had also defined. He also told us about hypoalbuminemia and edema, as well as hypercholesterolemia, which is not core. He took us through clinical evaluation and phlebotometry, vaccine status, and all of that. He took us through the initial workups, which include the standard labs, urine tests, immunology panel where necessary, imaging if indicated. He had also mentioned that we don't have routine biopsy or genetic testing, except where there are atypical features present or steroid resistance or infantile onset. He also took us through the treatment guidelines for the initial episode, using daily prednisolone for 4 weeks or 6 weeks, depending on guideline, then alternate days, and no tapering during alternate day dosing. He also took us through the relapse treatment, through the steroid-sparing agents for those that are frequent relapsers or steroid dependent. He also took us through monitoring and follow-up, home monitoring, clinic visits, criteria for remission, and all of that. He also finally took us through the adjunctive measures in which we think about edema control, lifestyle, nutrition, prevention of thrombosis, infections, as well as some bit of bone health, and gave us the situations in which we should refer to a specialist, such as atypical presentation, positive family history, extremes of age, the congenital type, or those above 12 years, steroid resistance, frequent relapses, and drug toxicity. And finally ended with comparing the IPNA, KDIGO, and IBADA consensus guidelines. So he has taken us through all of this. And I must say it's been very enlightening. So it's time for us to go through 20 minutes of our question and answer session. There was already a question in the chat. That's why there was a question that stated, asked about the role of hyperlipidemia. I cannot find it again.
I can't find it on my.
But I think it mentioned, I think it was from Professor Kombi that asked what was the role of hyperlipidemia in the diagnosis of childhood nephrotic syndrome. There was a second question there that asked, when do we tail? I think that was referring to the prednisolone. So
Okay.
those two for now. I remember I saw them, even though I can't find them right now.
Okay, so thank you very much, Prof, for your question. So hyperlipidemia is, like I said, one of the main features that you would see. So it's a consequence of the loss of albumin in via the kidneys. So the liver would compensate by producing, the entire mechanism to try to compensate for the loss of albumin, and that is how we have dyslipidemia or cholesterol. So technically speaking, if a child presents with nephrotic syndrome and his albumin is less than 30 and the child has edema, you would want to also add on your total cholesterol to just see what is the cholesterol doing. And if the cholesterol levels are high, it totally supports that this child has nephrotic syndrome, especially when you have a little bit of blood in your urine and you are worried that this child has an atypical presentation. So that will help you a great deal. I hope that helps.
I hope it responds to Dr. Adekombi's question. I hope I got that question right.
I can't see the question.
Yes, I didn't find it anymore, sorry. There's a second question from Alethea, asked about, apart from the accolades, please, sir, can we use normal saline or Ringer's lactate for patients in shock if albumin is not available?
Yes. So the most important thing is that if you do not have albumin and the child comes in shock, the guidelines say use a crystalloid. So you can actually either use a balanced crystalloid for that matter. So there is a drift towards using Ringer's lactate. But if you do not have Ringer's lactate, you can still use your normal saline. So use normal saline or use your Ringer's lactate, what you have, bring the child out of shock first, and then manage the child. And if you can then have access to albumin, you can swap to albumin. Now, usually we would have just your 20, what is readily available. At least I know in Port Harcourt, we have the 20% albumin. If you wanted to get your 4% albumin, then you would also have to dilute as well. So yeah, you can use either Ringer's lactate or normal saline, depending on what you have available. The most important thing is to bring the child out of shock.
Okay.
But then again,
okay. Go ahead. So.
Yeah, again, if the child has liver impairment for any reason, you know that the lactate that Ringer's lactate has to be metabolized in the liver. So you would have to be cautious using Ringer's lactate. But normal saline Ringer's lactate can still be used.
Okay, the next question was asking about if antacids can be given, since it's supposed to be a single dose. I assume the person is referring to the prednisolone being a single dose. So can we give antacids as it may, prednisolone may cause gastritis in some patients?
Thank you for your question. So the trials and studies, first of all, the guideline doesn't recommend routine use of proton pump inhibitors or H2 receptor blockers. So technically, no, because reviews have shown that that dose that you're giving the child is not enough to cause gastritis or cause peptic ulcer disease or worsen one. So the question is, if the child, so it will be on an individual basis. If the child does have peptic ulcer disease or is on another medication that can maybe like an NSAID for whatever reason, then you may want to give your inhibitors. Remember, using inhibitors like most people would prescribe omeprazole for them also have their own side effects as well. So they can cause hypomagnesemia and also cause interstitial nephritis or cause problems with the kidney as well. So generally, it's not recommended. Yes.
I agree with you, although we've had cases where some don't tolerate the steroids at all and have very bad cases of gastritis where we may have to prescribe some of these to ease the intake of that medicine, the steroids. The steroids can be quite harsh on the gastric lining, particularly when you're giving the high dose initial 2 per kilo dose. Yes. There is a question from.
Just to add to that,
yes,
so one way to help is to make sure that the child takes it after food. So it will help help the tummy, the stomach lining. So that child can actually take the prednisolone after his food. That would also help as well.
Yes, that helps. Although recommendation is on an empty stomach.
Neither here nor there.
That's the part that can be quite confusing. It's usually single early morning dose before meals, but taking it with meals or after meals actually helps the tummy issues. There is a question here from Prof. Moneke. Using the Bayero consensus after the 664 scheme, do you stop steroids completely? Are you not afraid of a quick relapse after that?
So it depends. Is the question for a first onset nephrotic syndrome? Because if it's for a first onset nephrotic syndrome, now the Bayero consensus says 6, 6, and 4. And then some part of the guideline says that you could give the child on low dose steroids. But I think that was applying to patients who are relapsers, not necessarily your first time presenter. So your first time presenter, the Bayero consensus was just saying, do your 4 weeks and your 6 weeks initially. And I think that came up from reports about the suspicion of children who are more like late responders in our own setting. So we tended to drag up to 6 weeks and knowing fully well the implications of labeling any child steroid resistant. So that came on, and then we go on for another 6 weeks, and that 4 weeks is where they say, go ahead and taper. After tapering, stop. Yeah.
Yes, absolutely correct. That's what we decided at that consensus meeting. There's another question from Jennifer. Please, I'd like to know how to estimate the dry weight when using the body surface area to calculate the dose of prednisolone.
Okay, excellent question. So there are different ways to estimate dry weight. One is, which is the probably gold standard, if you had a previous weight of the child. So you knew the child before the child came on with a nephrotic syndrome episode, that dry weight is the best to use. However, there are other ways. One would be that you could estimate the child's, so some people, like I said, okay, there are other ways. One would be you could estimate the child's percentage of fluid overload. So if the child is mild, moderate, or you say very severe, some people, there is calculating the child's present weight now with the edema, subtracting it from a percentage of what you think the weight is. That can also help you estimate what his dry weight is. Some other people will also say, use the child's height, 50th centile, and then check the 50th centile of the child's weight. You can use that as an estimate of what this child's dry weight should be. Then there is also using the formulas we know from the APLS and all that. But the problem with using those formulas is that there's a tendency to still underdose such children. So body surface areas, yes, you can estimate getting their dry weights like from what I have said. Yeah, I hope that helps.
Okay, what's the role of statins in severe hyperlipidemia in the management of nephrotic syndrome? This is by Dr. Tewese.
Thank you, Doc. So as it stands now, there is still no recommendation for the use of statins in these children because nephrotic syndrome is, well, technically a remitting and relapsing. So when they go into remission, the lipids levels normalize. So at that particular point in time, there really is no need. But if the child has now developed something like CKD and the child is having dyslipidemia, there may be a place for steroids, but that is for statins, but that would be when the child is above the age of 12, 13, according to the CKD guidelines. But by that time, that child should be with a pediatric nephrologist. So with the practicing pediatrician, the use of statins, no, there is no role as it is for acute nephrotic syndrome.
Absolutely. Are you saying, now this is from Dr. Koyemi Jegede, are you saying we don't have alone anymore once the patient has had it at the initial dose and then 40 milligram per meter square on alternate days for 4 to 6 weeks? After that, no more taper?
Yes, please, no more taper.
Okay.
No more taper from the guidelines, no more taper.
Okay.
So I think, okay.
Go ahead. Go ahead.
So I think the issue with tapering was the fear of upsetting the circadian rhythm that occurs with your steroids, as in the cortisol levels. So, but now it has shown that people do not have adrenal crisis or have issues with severe adrenal suppression when you give your steroids and taper and stop abruptly. So right now, both the trials that have been done did not report that tapering is necessary anymore. And so what we're trying to move towards is reducing steroid exposure as much as possible.
Yes, that will be probably after we've reviewed the Ibadan consensus criteria, which we did about 5 or so years back. Because for now, that criteria we still do 6-6 and taper.
Yeah.
Okay. Another question from Fong Obong Okon. What will be the specific roles of pediatric nurses for this condition?
Thank you very much. That's excellent to have a nurse on board. I'm grateful. Thank you for coming. So the nurses, your role will
You're assuming it's a nurse. I'm not sure, but
oh, okay. All right. Okay. But then it's a good question. So the nurses will play a major role, especially when it comes to education, and training of the family before they go home. Nurses also have a simpler way of explaining things. They are on the ward, so they can help the mom teach the mom how to monitor the child, weight measurements for this child, ensuring proper blood pressures are taken, daily dipsticks, and keeping charts, and paying attention to salient blood pressure flips or reduced urine outputs will go a long way as a nurse. And the nurse can also teach the mom how to take her medications and relate any what would they call it, fears to the doctors if they are not able to talk to the doctors. So yes, the nurses do really help. And when the patients come to the clinic, the nurses also play a role, encouraging the patients to have a void so that they can check their urines, encourage the mothers to keep charts, check the blood pressures of the children, and their heights and weights before they send them to the doctors.
Okay, there is another question from Jen Van Defo. You mentioned that you would not like to use ACE inhibitors and ARBs for the atypical nephrotic syndrome. I don't use that term anymore. She would like to know the reason why you would not like to use ACE inhibitors and ARBs.
So I said ACE inhibitors or ARBs are not used for the child who comes in shock or who comes in hypovolemia, or a child who comes with nephrotic syndrome and you are concerned that this child shows signs of decompensation. That's because your ACE inhibitors will affect some part of the glomerulus, the efferent arteriole of the glomerulus, and will cause, vasodilatation. And it's going to reduce glomerular filtration pressures, which will in turn cause an AKI for the child. It can also increase the potassium levels of this child and also make the child have, so those are the two major things that will come to mind when we say don't give ACE inhibitors. You can worsen the child's condition and make the child have an AKI.
Okay. There is before I take on the next question, there is a comment from our birthday girl. I'm very specific about the girl part of it because when you see her, you know she's a girl. Few comments. Apart from appreciating you for the presentation, some centers no longer rely on the presence of hyperlipidemia to make a diagnosis of nephrotic syndrome. Again, fresh frozen plasma is an option in the absence of salt poor albumin. This is from Prof. Former Anochi, our birthday girl.
Well, thank you, Prof. Thank you, Prof. I know that that is an option, but not necessarily from the international guidelines. We know our challenges, and we know that although fresh frozen plasmas may have their own complications and the risk for the fact that they may be high and they may be a little bit high in sodium, and they may also contain, you know, the risk for infections as well. So overall, I hear you, Ma. Thank you very much.
Okay, 2 comments before I take the last question. Mfongobong is a pediatric nurse, and I'm giving you a big clap for this because she attends all the PAN-CPDs. Dr. Korede also mentioned here a comment that you can use body composition machine. That's if you have, or if your center
exactly
to estimate dry weight, weights available.
Sure.
Yeah, there is a question by Mwanaidi Nkwizu. Sorry, I crucified that name. Why is it recommended to take steroids in the morning rather than evening in nephrotic syndrome?
Okay, so simply put, you are trying to mimic the circadian rhythm of prednisolone or cortisol release in the body. So when you give it in the morning, usually the circadian rhythm makes cortisol secretion higher in the morning. So you do not want to, you want to follow the pattern of the body. And when cortisol levels are high, you give prednisolone at that point. The body, you sort of trick the body to think it's the same cortisol that is being released from the body. But when you give it in the evening, when cortisol levels are low, then it sends negative feedbacks and makes the cortisol not available when it is necessary. So the child now begins to have low cortisol levels and will have issues with cortisol adrenal issues subsequently. So that's just simply put why we want to do it.
Yes, absolutely correct. We know adrenal glands produce cortisol usually early, about 6 to 8 a.m. So many times when we say take the steroids very early, first thing in the morning, sometimes we could just say 6 o'clock in the morning.
Yes,
so that at that time to mimic our natural cortisol rhythm. And I don't see more questions. And I'm not sure I can see raised. Oh, no, there is a raised hand from Asinovi, our mama. Please, ma, can you unmute? Yes.
Thank you very much. Can I be heard?
Yes, ma'am.
Thank you very much. I'm so proud of you both. Thank you, Dr. Briggs.
Thank you, ma'am.
Thank you.
Ma?
Patience.
Okay.
Thank you very much. You went through, I mean, it was very detailed and lucidly presented. Professor Anoche had mentioned one of the things I wanted to talk about, that for those who cannot get the salt poor albumin, that we've used fresh frozen plasma, you know, with good results. I want to commend you and the organizers for treating this topic, which is still a big challenge in our practice. But we'll say that things have improved over the years. You know, it's not nephrotic syndrome doesn't scare one as much as it used to do, because many of our patients are becoming steroid sensitive. Thank you. God bless you all.
Thank you very much, Ma. I didn't mention, Tonya, you have plenty of accolades. You know, there were several that were just to give you accolades for the presentation. I do not see any more hands. Suffice it to say that this topic is sometimes difficult for certain people, but if you can diagnose properly and do that initial management in good time, in the recommended time, I do not think would have that much challenge in managing straightforward steroid-sensitive nephrotic syndrome. Now, where we have challenges are those other ones, as Briggs has mentioned, the frequent relapsers and the steroid dependents, who are also part of the steroid-sensitive nephrotic syndrome. At this point, I'll revert back to our president to give us the PE to give us closing remarks, or Dr. Profogunleshi. I think he'll be the one to give us closing remarks. Sir, are you on?
Thank you very much, Dr. Page.
Okay, ma'am. Okay.
I think it's on, but thank you very much, Dr. Page.
Yeah, I just saw a message.
Very nice
okay,
and thank you so much, Dr. Datonye. Thank you very much, Dr. Datonye Briggs. That was very lucid. I really understood a lot of things. And as I was going through, I saw our powerful pediatricians in the house, including the birthday girl.
Yes,
so
girl.
We like to thank PNAN, who is also a past president. So we'd like to thank PNAN for this unraveling this area that sometimes is gray. You know, a lot of us are not in nephrology. We don't know so much as advanced. So we thank you very much. Dr. Datonye, it was so lucid. Everybody's really giving you the accolades. So PAN appreciates your facilitating and being a speaker for this session. And we appreciate the collaboration with PNAN and all our subspecialty that continue to educate us and improve our education, especially when you're not in that specialty. You really gain so much. We'd like to thank all our members for tuning in. Happy Salah. Now I'm going to go and look forward to eat my own Salah ram. And happy Children's Day. We just finished our activities, so it's a very beautiful day.
Sorry to interrupt you,
President. And I say,
sorry to interrupt you, ma. People are asking about the slides. Is it going to be shared to participants?
Oh yes. It will be shared.
So yes is the answer.
You get it. Yes, and then you also get the CME credit for it.
Thank you, ma'am.
So have a nice day, everyone, and thank you for coming. Barika.
Thank you.
Bye,
ma'am. Thank you. Thanks, Briggs.
Thank you.
Thank you.
Thank you, everyone.
Dr. Briggs, well done. Professor Obiagwu, well done. Thank you.
Yeah, Martha, thanks.
Thank you, everyone. Thank you.
Briggs, well done.
Thank you,
yeah, very
you,
nice. Very
Thank
nice.
you so
President,
much.
did you clone yourself?
I don't know. I thought she was in a party.
I can be in multiple places. And then asking my t-shirts now, you know.
I can imagine. Thank you.
President, put our cake in the fridge, Joe. I know there is plenty of cake happening this week. This week has
there's
plenty
cake. Come and get it. Yes, so we're expecting you now. Don't tell me you're not going to land.
We'll see. Thank you very much, ma. Have a lovely day.
Like me.
I almost carried the laptop on the way.
Too. Thank you. Yeah. All right. Good night, everyone.
Bye. Bye from me.
Thank you. All right. Bye, everyone. Yes. Thank you, ma'am.
Our birthday girl. Thank you very much. See you soon or later.
Thank you.
Bye, Prof. Anoje. Happy birthday.
Everybody knows the secret. It's an open secret.